Welcome everyone, thank you for joining us. We are now going to start today's webinar. Before we begin, I'd like to go over a few details for today's webinar. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. To ask a question, use the chat feature that is on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. We will answer questions at the end, after all of the presentations are finished. With that, I'll turn it over to Dr. Amy Eden, who will kick us off.
Hello, welcome everyone. My name is Amy Eden. I'm the director of AHRQ's National Center for Excellence in Primary Care Research, or NCEPCR, because that's quite a mouthful. We're so happy that you are all able to join us today and that we have this opportunity to host this webinar, even during a time of change and uncertainty for AHRQ, for HHS, and really the federal government overall. We really appreciate the opportunity to continue to share with you and the public some of the critical work of AHRQ and of NCEPCR. So again, thank you so much for joining us. Next slide. Just to briefly give you a little overview of NCEPCR. Its mission is to support transformative primary care research, tools, and methods for implementation, and also to support the next generation of primary care researchers, all to improve the delivery of primary care. To achieve this mission, NCEPCR engages in these key activities that you can see on this slide. This webinar, the webinar series of which this webinar is part of, highlighting the value and impact of primary care research, represents one of our efforts to communicate important primary care findings. And it's just one part of a more robust dissemination strategy. Next slide. Before we jump into the webinar content, I just wanted to highlight a few AHRQ resources relevant to today's topic. First is AHRQ's Compendium of U.S. Health Systems. It's a public resource which includes annual data files on characteristics of healthcare organizations over time, and it really enables users to see the changing structures of healthcare organizations. In particular, relevant for primary care research, the collection of data includes an outpatient site linkage file, which contains street-level information on over 283,000 sites. Site specificity specialty data can be used to identify and study primary care practices. And in addition, the group practice linkage file can be used to link primary care provider data with information on system affiliation and parent owners. Each of the files provides insights on ownership relationships and system affiliation in primary care. And you'll get to learn more about the compendium in a few minutes in our first presentation. And then another resource that has implications for the impact of shifting ownership trends in primary care is the technical brief entitled Measuring Primary Healthcare Spending, which was recently published by AHRQ's Evidence-Based Practice Centers. And just a really high-level insight, the authors found that the ways in which primary care spending is measured really varies greatly across state, regional, and national estimates, making it really challenging to make comparisons and also limiting our ability to understand the impact of policies. The authors call for a consensus definition of primary care that specifies clinicians, locations, and services that can be reliably identified and used to estimate spending. Next slide. So I'm really looking forward to hearing from 3 AHRQ-funded presenters about their really important, also very innovative and timely research on the impact of consolidation and ownership on primary care. The objectives of today's webinar are to learn about the impact of health system vertical integration across a range of quality, utilization, and spending outcomes. to learn about the effects of private equity ownership in primary care, including associated changes in key clinical and workforce outcomes. And then also to learn about the impact of health system ownership on achieving high quality primary care and whole health, and how ownership and other contextual factors may impact care. So just a quick note, today's webinar and slides will be made available later on the AHRQ website, where you can also find recordings of previous webinars in this series and our last series, and also register for upcoming webinars. Slide. And with that, I'm really honored to introduce the moderator for today's webinar, Dr. Kevin Grumbach from the University of California, San Francisco, and just an amazing primary care family physician and primary care researcher. Dr. Grumbach will introduce today's presenters, will facilitate the Q&A and discussion after the presentations are finished at the end. So welcome, Kevin. I'll turn it over to you.
Thank you so much, Dr. Eden. It's really terrific to be here, and thank you for introducing this setting. Look, folks, welcome to everybody attending the webinar, to our fabulous presenters who are doing really, I think, innovative and important research. I think we can't have this webinar today without starting by acknowledging the times we're in, and this is a poignant moment here to have this AHRQ webinar, given all the events happening with federal agencies. And, certainly the Agency for Healthcare Research and Quality is among the agencies buffeted by a lot of actions happening at the executive level. I think this webinar then really serves as a reminder of the incredibly important, relevant work that AHRQ has been doing in primary care research and research and implementation science and quality improvement more broadly for the health system. Amy mentioned that there are these incredible resources like the Health System Compendium that have been funded by AHRQ, the technical brief on sort of methods for measuring and defining primary care spending that have incredible importance to actions happening both at the state and federal level as part of the effort to strengthen primary care. So I want to personally thank Amy and all of her colleagues at AHRQ for hanging in there. I mean, it is an objective fact to say it's distressing showing up to work every day not knowing whether your ID card will open the entrance or give you access to your computer. And we really appreciate our public servants who are still doing such critical work and making today's events happening. So thank you from me, and I think on behalf of all of us, for your service. The show must go on. So, really grateful that we are able to proceed with today's webinar. Again, thanks to both AHRQ and APT Global for organizing the event. It's extremely timely topic today of healthcare consolidation and the growth of investor ownership in healthcare and how it is affecting primary care, both primary care practitioners and workers, as well as patients and communities served by those primary care practices. So if we go to the next slide, please. We have three really stimulating presentations. I'm pleased to introduce you to Dr. Amelia Bond. Dr. Bond is a health economist who's an associate professor in the Division of Health Policy and Economics in the Department of Population Health Sciences at the Cornell School of Medicine. She's going to be giving a presentation on vertical integration, looking at trends both in healthcare organization, ultimately effect on care of medically complex patients who are Medicare beneficiaries. Dr. Marshall Brooks is a cultural and medical anthropologist who's an assistant professor in the Department of Family Medicine and Population Health at Virginia Commonwealth University. He is going to be sharing his work looking at primary care practices in the state of Virginia and looking at, again, trends in changes in ownership and consolidation and how that may be associated with achieving high quality or perhaps being set back on the aim of achieving high quality primary care. Dr. Jane Zhu is a practicing primary care physician, as a general internist. She's an associate professor in the Division of General Internal Medicine, with also an appointment in Health Systems Management and Policy at Oregon Health and Science University. She's going to be sharing her work looking at trends in private equity acquisitions in primary care, and again using Medicare claims data set to look at how that might be associated with the care of Medicare beneficiaries. These, as Amy mentioned, but I really want to highlight, all three of these projects are funded through AHRQ grants. I think, again, reflecting AHRQ's ability to really invest in work of great resonance to what's happening to the changing landscape of primary care in the United States. These people, I think, tune in these presentations to both the methods, for those of us interested in how do we study these issues of practices and their association with health system. So I think you're going to get a lot of insights into methods. All three will share some preliminary findings. And then what you're going to get is a bit of a, I guess, a coming attraction trailer, because they don't have all the outcomes related results available yet. These are all studies in progress. So I think they're going to titillate you a little bit with what's to come as they proceed with continuing work on these three great studies. So let me then, without further ado, turn it over to Amelia Bond, who's going to give our first presentation. Amelia, thanks so much for being with us today.
I'm thrilled to be here. Next slide, please. First thing I want to say is this is teamwork. Big team is helping with this AHRQ funded R01. My co-PI is Dhruv Kular at Weill Cornell. And I also want to specifically highlight a handful of people on the Cornell side: Yasin Sivilek, Kayla Tormolen, and Manuel Zhang, as well as on the Mathematica side, Dave Jones and Sandy Nelson have been instrumental in helping put together this first kind of half of this presentation on expanding the compendium of U.S. health systems. Next slide, please. Okay, I'm going to do a very brief motivation. I think a lot of people are here because they know a lot of the things in the next couple slides. So I'll say briefly that health systems are really big and they are growing. This is from a paper published in Health Affairs by Mathematica, and actually an AHRQ colleague, Michael Furukawa, using the first 2 years of the compendium of U.S. health systems. And here I want to look at the proportion of physicians that are tightly affiliated with health systems. And then also on the right-hand side, the number of hospitals and hospital beds in health systems, and it's just high. So in 2018, 50% of physicians tightly affiliated with health systems. The hospital beds in 2018, almost 90%. Next slide, please. When we zoom into primary care physicians, health systems really outstrip any other type of corporate ownership. This figure on the right here is from Yashaswini Singh and colleagues at Brown, and they're looking at this tight affiliation at the hospital setting. If we looked at the health system, it would be very similar. She also has plotted here private equity affiliated primary care physicians. That's something Dr. Zhu will be talking about quite a bit later. One other important entity that we aren't going to be talking about today are payviders, so insurers and Optum, for example, employing a large portion of physicians. That being said, health systems are still by and far the largest employers of primary care physicians right now in the country. With that being said, there's been, and this trend going on for some time, there's been quite a bit of work. And prior work suggests that upon acquisition, the prices that practices charge increase. However, it is less clear how delivery patterns and quality might change. There is, I cite here a handful of studies, there are many others. Overall evidence somewhat mixed, and it depends maybe a little bit on the specific context and the setting. In our grant, we plan to focus on medically complex patients. We think that these are the patients that could be most kind of benefited or most harmed by any change in the delivery of care. And then why we are here today is we think primary care physicians specifically play a very special role. They should be hopefully the first point of contact and therefore your access to the healthcare system. Next slide, please. And so our question for our grant, not necessarily this presentation today, is whether and how health systems change the delivery and quality for medically complex Medicare beneficiaries with a real focus on primary care practices when they are acquired. Next slide, please. In this presentation, I'll be focusing on two kind of elements that we need to put together in order to accomplish this, this first part of our grant. One is we need to construct this database that says whether or not a primary care practice is a part of a health system and when they became a part of a health system. And so we are expanding the compendium of US health systems from 2012 to 2019. So we're kind of going backwards. In the next slide, I'll talk a little bit about in a little more detail what that is. Could you go back one more slide? The second thing I'll be talking about is talking about some initial findings on how we think about primary care and how that might have changed over the decade. Next slide, please. Okay, so I'm gonna spend less time than I thought talking about this, as Amy did a wonderful job talking about it already. The compendium of US health system is a wonderfully and currently publicly available data created by Mathematica through AHRQ's Comparative Health System Performance Initiative. There's a QR code that can also get you there. I think it's been shared in the chat. Next slide, please. And this, as Amy had mentioned, it includes a list of health systems, a list of hospitals linked to those systems, and very importantly for us, a list of group practices, which in our work we think about as TINs, tax identifiable numbers, linked with systems. Something new for 2020 onward that Mathematica is constructing are files for outpatient, nursing home, and home health care organizations. Next slide, please. So Mathematica has made this available, and AHRQ has made this available for years 2016, 2018, 2020 to 2023. Next slide, please. And so what we're doing, because in order to apply kind of causal experimental designs, we need a longitudinal panel. And so we're going to be expanding this compendium of US health systems backwards and constructing it from 2012 to 2019. We're going to do the best we can applying Mathematica's methodology, and then we'll also be making this publicly available. Next slide, please. The data we're using, we're going to be using the 20% traditional Medicare file, the American Hospital Association annual survey, and then IQVIA's healthcare provider and organization data, also known as HCOS. Next slide, please. One thing that I wanted to take a couple moments to say during this presentation is that an important file that is very relevant for all of this corporate ownership analysis is what's called the Provider Enrollment Chain and Ownership System Database, or PACOS. That's kind of a hodgepodge of which institutes or researchers have access to this. This is something we do not have access to and is not broadly available. This is something, if you have the ability to nudge or encourage broader access, that would be very helpful for the research community to do research like this. Next slide, please. So not having the PACOS, we're still able to construct kind of the set of health systems the way that that Mathematica has done. We're using the AHA data and HCOS data. We're essentially saying we don't believe either one of these files is the gold standard and always perfect, but when we combine them, we think when they match, we're going to believe that they are true. When there's difference, though, we're going to spend a lot of time doing manual review. And so this is something that is a very laborious and time-consuming process where a lot of coding and manual review, and we have a wonderful team of RAs helping to do a lot of that. This last bullet here, something that Mathematica did not do that we are taking the time to do, is comparing system structure over time, because that's very important for our kind of quasi-experimental work. Next slide, please. One thing that I do want to mention that Mathematica is very thoughtful about is that the system, it's defined to be this vertically integrated entity. So it needs to be a hospital as well as 50 physicians and 10 primary care physicians. Next slide, please. And the second part of constructing this compendium is identifying which TINs, which practices are associated with this health system. This is where missing PACOS is really important, and we've got to deviate a little bit from Mathematica's method. They use kind of 4 methods in order to match practices with systems. We can only do 2. Next slide, please. And so what we do is we apply Mathematica's method with those 2 options, and then we also identify kind of more stringent thresholds where if they only match in one rather than both methods, we're going to say that, okay, this practice is in fact linked to this health system. Next slide, please. And we think we're doing a pretty good job. So for example, in 2016, we think that we're identifying 94% of practices and 95% of practices, and that matches Mathematica. Next slide, please. So that's kind of the first part of the presentation, talking about this really big database that, stay tuned. We hope to finalize that very shortly and make that publicly available. The second part that we want to spend time doing is thinking about, when a primary care practice is acquired, what does that practice look like and how has that changed over time? So this is some work that will be forthcoming later this month in JAMA Health Forum. And what we're asking here is whether the practice setting and practice type has changed for primary care visits. Here we're focused on traditional Medicare enrollees, and when we're thinking about a setting, we're thinking about whether this is in an office, a federally qualified health center, rural health center, or other type of setting. For practice type, we're thinking really whether this is a single specialty or multi-specialty, and then furthermore, what that multi-specialty practice looks like. What proportion of physicians are primary care physicians? Next slide, please. So here we've identified the universe of primary care visits in the 20% claims in 2 years, 2012 and 2022. Amy had a nice comment about AHRQ spending time constructing this analysis, thinking about how do you define primary care spending. It's really tough, in part because we don't know whether NPs and PAs are primary care. So here we have to limit to just primary care visits billed by primary care physicians. And then we also say that anything that's delivered in a federally qualified health center or rural health clinic is a primary care visit. So we're going to look at the practice setting and practice type. We're also going to reweight our 2012 sample so that certain demographics match the 2012 sample to account for maybe changes in those demographics due to MA growth. Next slide, please. And so this is our results looking at the primary care setting. On the x-axis, we see the different settings, so physician's office, rural health center, HOPD, et cetera. On the y-axis, we have the proportion of primary care visits. This dark blue bar is 2012. The lighter blue bar is 2022. The white bar is very similar to the middle one, so we'll focus just on 2012 versus 2022. And we see this 10 percentage point drop in the proportion of visits that are delivered in a physician's office, whereas we see kind of a somewhat commensurate increase in the rural health center, hospital outpatient departments, and federally qualified health centers. Next slide, please. Now this graph is limiting just to visits delivered by primary care physicians. We do not have FQHCs and RHCs here. And again, the bottom here is the percentage of primary care physicians in a practice. So all the way on the left, we're talking about practices that have very relatively few primary care physicians. The vast majority of physicians are specialists. Whereas on the right-hand side, we either have these solo practitioners, there's only one primary care physician in their practice, or practices where almost everyone is a PCP. And here we see this really large percentage point decline in solo practitioners from 2012 to 2022, and the biggest increase in these multi-specialty groups where the majority are specialists. So we see this biggest jump for the 20 to 40% PCP practice. Next slide, please. Okay, so wrap up, talked about two very separate things that are necessary to do this work. First, our group has spent a lot of time constructing this compendium of U.S. health systems, working with Mathematicus methodology and going backwards. We'll be making this publicly available in the future. We also have some work forthcoming this month where we look between 2012 and 2022 and see a sizable shift in where primary care visits are being delivered, a large increase in FQHCs, RHCs in the hospital setting, and also a substantial decline in visits to solo primary care physicians, and really an increase in these multi-specialty practices. And wrap up the future work, we hope to answer kind of a primary question. So what is the impact of primary care practice acquisition on the delivery and quality of care for medically complex Medicare beneficiaries?
Amelia, thank you. There's, I know, references, but terrific. And just to remind folks, we're going to do a question and answer at the end after all three presentations. So start thinking about questions that may be prompted by Amelia's terrific presentation, while I am now going to introduce you to Jane Zhu. As I mentioned, Dr. Zhu is at Oregon Health and Science University, and her presentation will focus on sort of similar, looking at large data sets to look at trends in private equity acquisition of primary care practices. Jane.
Thank you so much for having me, and thank you to AHRQ for hosting this webinar, as well as to my fellow presenters. So next slide, please. Like Amy, Dr. Bond mentioned, this sort of work is really a collaborative effort, and so I want to acknowledge our incredible team here, including my co-PI, Zuri Song, who's at Harvard, and we're particularly grateful for the funding and support from AHRQ to support this, this work. Next slide. So many of you may have heard about private equity investment in healthcare growing rapidly over the past decade. Many of us have heard through the news notable cases like Steward Healthcare in Boston and Hahnemann Hospital in Philadelphia, and this has really attracted a lot of growing attention from media and policymakers and the public of late. Private equity firms have acquired hospitals, nursing homes, and more recently, I would say over probably the past 7 to 10 years, physician practices across a number of specialties. This map is from a health affairs paper done by the Schaefer Center at USC, and they found that in more than 100 metropolitan areas, a single private equity firm holds at least 30% market share in one medical specialty, and in another 50 metropolitan statistical areas, private equity holds more than 50% market share. And so these trends, particularly the rapid sort of penetration of private equity and consolidating these local markets, is raising concerns about the effects of private equity in healthcare consolidation, potential changes in healthcare delivery and pricing as well. Next slide. So why do we care about private equity specifically? Some of you may know, but it is a form of private capital. There are a lot of different investment vehicles, and concerns have really centered around private equity, LBO or leveraged buyout models in particular. And I would point out a few reasons for this. Unlike venture capital and growth capital models, which require private equity investors to take on high risk, leveraged buyouts are funded primarily by debt or with borrowed money from banks. And that debt is actually loaded onto the acquiring company to pay back. So you can think of that financial structuring as perhaps motivating cost-cutting measures in order to make the profits that they're expecting. A second reason is that leveraged buyout models involve controlling or majority stakes in companies. And so that gives private equity firms potentially significant influence over business decisions. For example, how care is delivered, what services might be prioritized, how clinicians are scheduled or compensated. And in primary care, financial margins, as we all know, are quite thin to begin with. And the book of business is really on physicians and the clinicians and their relationships with patients in a longitudinal manner. And so this model raises questions about how private equity ownership is potentially affecting care delivery in primary care particularly. Next slide. So further motivating this question is early evidence that's come out of other sectors. There's been a number of studies that evaluated private equity's effects on hospitals and nursing homes and procedural specialties like dermatology and ophthalmology. And all of these studies have suggested increases in prices, shifts in service volume, and the types of care provided. The event study figure on the left is from a paper in JAMA Health Forum that found increases in total spending per practice, increases in charges, increases in allowed amounts after private equity acquired procedural specialty clinics. And these findings have really been replicated across settings. Evidence on quality of care has really been more mixed. Some studies have shown potential improvements in process measures. Others, and this is particularly true in hospitals and nursing home settings, have shown increases in avoidable complications and even in mortality. But little is known about private equity's effects in primary care, where investment has been much more recent. Next slide. So this is the focus of our overall grant that's funded by AHRQ. We're really centered on two overarching research questions. First, what are the effects of primary care ownership in primary care? And second, how do PE strategies differ in traditional fee-for-service Medicare, where volume of care is more incentivized, versus in Medicare Advantage, where many of you may know the incentive is to increase coding intensity to maximize risk-adjusted payments from the federal government. So understanding the differences in these different markets can really help us to assess sort of the heterogeneity of strategies that private equity firms might use and what that means for patients and the healthcare system. Our specific aims are to measure how private equity ownership changes provider behavior. Second, to examine how these acquisitions affect quality of care and patient outcomes. And third, to explore whether these effects vary by patient and provider characteristics like race, geography, or practice size. Next slide. Like Dr. Bond mentioned, this is work that is sort of mind-numbing because of its sort of involvement of manual verification and data manipulation. I'll just briefly review our broad approach. First, we want to identify PE acquisitions and the clinicians working in those practices. We then link this data to comprehensive Medicare claims and Medicare Advantage encounter files. We compare patients treated in private equity-owned practices to those in non-acquired independent practices that are otherwise matched or similar across a number of key domains. And finally, we use a difference in differences approach to estimate the impact of private equity ownership on a number of outcomes. Next slide. The outcomes that we're interested in for traditional fee-for-service Medicare, we're looking at service use and spending, particularly for low-value services. And we focus on low-value services in particular because, like unnecessary cancer screenings, imaging testing, because they have not been studied to date and they're sort of more nuanced outcomes. And for Medicare Advantage, we're interested in assessing risk coding, whether private equity practices are more likely to document higher risk conditions that increase reimbursement. Along quality domains, we're looking at emergency department visits for preventable conditions, preventative care measures, and the use of high-risk medications amongst the elderly. Next slide. So, like I said, identifying private equity-owned practices and their affiliated clinicians is a particular challenge for this work. There are no existing databases of practice ownership that are highlighting private equity ownership in particular, and there are no laws requiring private equity firms to announce their transactions of medical practices. So we have to rely on proprietary merger and acquisitions data. So we use PitchBook as a scaffolding really to track transactions. And then we manually verify and expand our acquisitions data using web-based searches of private equity portfolio websites, clinic websites, press releases, And then we link these acquisitions to the IQVIA One Key database. Dr. Bond mentioned there's a lot of different other potential databases. There are advantages and disadvantages and trade-offs with each of them, which we may have time to discuss at the end. But using the IQVIA One Key database, this provides us detailed provider and practice level information. An advantage is that there's MPI, so National Provider Identifiers, and these can be followed over time, which allows us to build a longitudinal data set at the MPI practice year level. When we linked the acquisition data to the IQVIA One Key database, we used exact and fuzzy matching algorithms based on clinic location, names, and we actually had pretty successful match rates. About 96% of our original acquisition list was matched successfully and verified to the IQVIA One Key database. And now we are linking our acquisition data to Medicare claims and MA encounter data by MPI. The 2022 Medicare data only recently became available this spring, so this work has been somewhat delayed, but that's where we are at this point. So I'll walk through a few early descriptive results that we've found thus far, but this is really focused a little bit more on workforce and trends, and I really want to emphasize that, again, this is a work in progress. Next slide. So in total, we've identified 643 practice sites that have been acquired by PE between private equity between 2016 and 2012. These practices are located nationwide, although there is clustering in certain regions and states, as you can see on the map on the right, particularly in the Southeast. Florida, for example, is a particular target of private equity in primary care. And this regional concentration is really consistent with what has been demonstrated in other medical specialties as well. Next slide. We're also seeing changes at the aggregate level. As an example, the number of practice sites grew after acquisition by about 15%. We saw increases in practice sites per corporate parent and clinicians per practice site. And meanwhile, this is sort of aligned with Dr. Bond's presentation, the corporate owners consolidated over this time. When we looked at clinician characteristics, the number of clinicians grew by about 30%, with a relative decline in the share of MD physicians in these practices, including those from the top 50 medical schools. And we saw a relative increase in the share of advanced practice providers after private equity acquired these practices. So advanced practice providers, MPs and PAs in particular. Next slide. This figure is showing the settings from which new entrants to PE-owned primary care practices are coming from and where leavers or exiters from PE-owned primary care practices are going. There's on the y-axis, there's shares of clinicians, so percentages of entrants and exiters. And then the x-axis is clustered by provider type and entry and exit. So if we look at the first cluster, for example, we see that about 60% of advanced practice provider entrants into private equity-owned practices had no prior employer, suggesting that private equity is really recruiting new NPs and PAs out of school or from other fields. About 15% of new APP entrants came from independent practices, that is the green bar, or other corporate-owned practices, that's the sort of dark blue bar, respectively. And we see similar patterns with new physician entrants to PE. That's the next cluster. Meanwhile, if we move further to the right of this graph, we see that the highest shares of APPs exiting private equity owned practices are no longer active, meaning they either retire, they might be leaving clinical medicine, or are no longer practicing in primary care. Whereas the last cluster is showing shares of physicians leaving private equity acquired practices, and relatively more even shares of physicians are going into other care delivery settings after acquisition. Again, this is all descriptive. Next slide, please. These are early event study figures, which show the differential change in new entrants to private equity acquired facilities relative to clinicians and independent control practices. And this sort of is consistent with the descriptive analyses suggesting in these figures that there are relative reductions in physician entrance into private equity practices after acquisition and relative increases in APP entrance compared to matched independent control practices. So taken together, these findings, along with other analyses we're actively working on, are really raising some early questions about staffing and labor changes and the implications of these changes on the larger primary care workforce, particularly given that we know there is a primary care workforce shortage in this country. Next slide. So our hope is that this study will continue to provide some of this empirical evidence on private equity's role in primary care. We're particularly interested in also offering some initial perspectives on workforce impacts, even as we're progressing on understanding the specific profit mechanisms by which private equity is affecting utilization and quality of care in the Medicare population. And the goal of overarching goal of our grant, particularly given that Medicare covers primary care for 60 million aging adults, is to understand to what extent private equity has positive and negative impacts on this system, and to help inform policies that can potentially mitigate the most negative consequences for patients. Thanks very much for having me.
And Jane, thanks. Another terrific presentation. And I see you're already stimulating some questions coming up in chat that we can circle back to after the next presentation. So if we go to the next slide, and let me introduce again, Dr. Brooks. Marshall's presentation is actually going to be very complementary to what you've heard from Amelia and Jane in terms of Marshall is not using large secondary data sets, but really using more primary data or working in a more direct way with practices in the state where he's located. So Marshall, thanks.
Thank you. And thank you all for being here, and thank you AHRQ for hosting this. I do think that the work I'm doing is, and I'm glad that it comes at the end of this, because I think it offers a little bit of an alternative viewpoint of how to assess some of these issues that have been brought up and these trends that we're seeing. So I'm a medical anthropologist by training, so I come at this issue a little bit from much more so from a social sciencey perspective. And so I've designed a mixed method study that gets at how two separate trends are impacting each other. And the one, as has been laid out here, is this trend of consolidation and monopolization of physician practices under health systems and private equity. And I'm interested in seeing how does that impact clinicians' experiences, perspectives, and behaviors, and specifically looking at that through the window of high quality primary care and whole health. Next slide, please. So again, as has been laid out, we see shifts in ownership of primary care practices across the country. And just as evidence of this, we can see that there's been a 68% of active AAFP members are now employed. 90% of new positions offered to new residency graduates are employed rather than independent. And so we see that this trend is going to be continuing in the future, for the foreseeable future, of more and more consolidation and more physicians practicing under employment contracts rather than private practice. Some of our preliminary data and preliminary work we've done in Virginia, and which was very much the impetus for this study, is we've seen a shift from 25% to 43% of practices, primary care practices in Virginia, being owned by a health system between just in several short years, between 2018 and 2022. And I'll go into those numbers a little bit more detail in how we got at that, because that shift is very important for how we're going to be approaching this topic, but also it helps describe a little bit of the sample that we're going to be pulling from and how we get at this issue. Next slide, please. So on the one hand, we have trends in consolidation and more practices operating under health system ownership and physicians operating under employment contracts. And I wanted to see how this imbricates with or is impacted by or impacts another trend within primary care of focusing much more on this idea of whole health. And I know this point has probably been belabored to most of you, and you know this, but these are whole health being articulated at least most cogently and most recently through the National Academy of Science and Engineering and Medicine reports in the Implementing High Quality Primary Care report and the Achieving Whole Health, a New Approach for Veterans in the Nation. And so to look at how so whole health being defined as something that as healthcare that is people-centered. So basically an approach to care that looks at people as embedded within the communities that they live and the families that they lived, and not seeing them as isolated individuals, that is comprehensive and holistic, so that it doesn't just account for their physical pains or their physical ailments, but it also encompasses their behavioral, spiritual, and socioeconomic well-being. So it's more comprehensive and holistic on that front. That it's upstream focused, that it accounts for and attempts to mitigate issues of structural and social inequalities and issues that are contributing to these downstream effects that we see when people come and enter into our practices. That it's equitable and accountable. So that means it's not perpetuating or aggravating issues of inequality or disparities, health disparities, but it's actively and proactively addressing those. And then the fifth dimension is that it not only ensures the well-being of the communities and the patients that are being served, but also looks to address the well-being of the clinical teams and the professionals that are providing the care. And I think it's worth reiterating this point, because part of what my study does is say, let's look at what are clinicians' perspectives of this whole health approach and the different domains that are in it, and how do they see their work either contributing to this or being benefited by or being undermined by consolidation trends. Next slide, please. So we have to look at, and this is an open question, coming at this issue as an open question, that there's potential benefits of consolidation. And when practices are being bought out by health systems or by hospitals or even potentially private equity, they're making a value pitch to them. It's not always a forced buyout, that there is a value pitch to them. And that essentially boils down to that they're going to be able to capitalize on economies of scale. So consolidation, meaning you're going to be part of a bigger fold, a bigger group, and you're going to have more resources available to you. And the promise is that through consolidation, through health system ownership, you're going to be able to reduce costs, improve quality, and expand access. And this is primarily through reducing redundancies in the system, centralizing resources, leveraging that larger market footprint to negotiate things like higher payment from insurance companies, and then being able to have the resources to invest in innovative technologies and infrastructure that will make providing care and high quality care easier and better. It also means that they might be able to incorporate more interdisciplinary teams into their clinics, to hire other types of clinical health professionals to come work and provide more integrative care. So to be able to expand the scope of work that you're providing, and that you're going to be able to expand access, providing more access to more ready-made referral networks, and so that patients aren't going to have to wait as long to get to the care that they need. There's also this idea that it's going to improve alignment between clinicians and organizations, such that clinicians can be more compelled to adhere to guidelines and evidence-based care, and that they'll do a better job at the provision of preventive services and more comprehensive care. There's also this idea that it's not only going to benefit the patients that are being served, but also the clinicians themselves. And so but potentially better fits the lifestyle goals of early clinicians, and who maybe don't want the responsibilities and risks of small business ownership and don't want to have to deal with insurance hassles. Next slide, please. Potential downsides to consolidation, though, is it may exacerbate clinician stress, impair patient interactions, and diminish productivity and contribute to turnover. And it does this through a couple different hypothesized ways. One, that it undermines the autonomy and local decision-making authority of the clinicians that are working in those practices. And that the increased managerial control and oversight will clash with clinicians' professional values and hinder that autonomy and limit their discretion and authority to make the decisions best for their patients. And we see that in some recent work that's showing employed clinicians report higher rates of treatment and referral interference, and that they see that the ambulatory focus of primary care is being replaced with more hospital-based interests. We also see that one of the mechanisms for this, in the way consolidation may undermine the work of primary care, is that doctors who are employed by hospitals and corporations seem to be reportedly more dissatisfied and burned out than those who work independently and in clinician-owned practices. And another survey has found that 50% of independent clinicians report lower empathy for patients as the result of clinician burnout compared to 72% of corporate or hospital-owned clinicians. So there's this ownership gap of 15 percentage points. So you're more dissatisfied and burned out, and as a result of that, in these corporate hospital settings, that you have lower empathy for patients. Next slide, please. And so when I came to this topic, what I saw is that there's a lag, there's several research gaps, and there's a lack of research on how primary care clinicians respond to and are affected by these shifts. So what does that mean for their perspectives, the experiences they have, and their behaviors, and what they're actually doing in clinic? And to what extent, and the question of to what extent we see hospital ownership facilitating or undermining practices' ability to promote what is being now defined as high quality primary care and whole health. So using these definitions from the national academies and seeing to what extent practices are being able to meet those and live up to those. And importantly, previous studies have overlooked the impact of, and I say this as this is more coming from that social science perspective, and also where we see looking at regional differences. And so understanding that care provided is local. And so that looking at the impact of regional differences and how do the different populations that different practices are serving across a state, like in Virginia, how does that impact practices' ability to provide this type of care, and looking at micro level variations in experiences across different health systems. So where you might have different regulations and policies, organizational cultures, or employment contracts under those different health systems. And also importantly is embedding this within a specific socioeconomic conditions. So this is all happening within a particular historical moment that is not unique to Virginia, it's not unique to primary care, and it's not even just unique to healthcare in general, that we see this corporate takeover of more and more public sector services and being able to, and I think it's important to be able to couch this within that those larger trends. Next slide, please. So I have two main aims. Again, just briefly, looking at whether or not that this advances primary care clinicians' ability to provide whole health care and high quality primary care, and to understand importantly, what are the other contextual factors that go along with that? So what are the things that not just the ownership, but what are the things that are within different ownership structures and contextual factors that inform that process? And I'm going to do this through an explanatory sequential mixed methods designed through multimedia elicitation surveys, and focus group interviews. Next slide, please. So just a little bit about our sample and the setting that we're working in. Primary care in Virginia, this is a map of Virginia, and in our previous work, we've used the M.P.P. and the APCD to identify every primary care clinician in Virginia, and we update this annually. And we're able to nest that by practice and health system, so having an idea of where these practices are located and where they're working. And so we've identified over 20,000 active physicians in Virginia, almost 6,000 of which are classified as providing primary care, and they are within 2,296 practices. And so we've taken this list and now survey these practices every 4 years, and we've done this twice in 2018 and then again in 2022, and we're getting set to do it again. And every year we send out a survey that changes a little bit each time, but we try to get some of the same metrics each time as well. So understand what are the current practice characteristics, their capacity, scope of work, and then importantly, changes and stressors experienced in the preceding year. Next slide, please. So from our surveys, we've been able to see that 83% of these practices that that we've engaged with are family medicine, internal medicine, some pediatric and OBGYN. We have a nice spread in terms of the geographic location, almost 50% in rural, and then the rest split between suburban and urban. And then in that third column, importantly, what we see is that, again, like I mentioned at the beginning, the shifts in hospital ownership. So in our 2018 survey, only 25% of practices were health system owned, and 53% were clinician owned, and that's now dropped. So now in 2022, in our most recent data, 29% are clinician owned. And then we can also see in that fourth column that we have a wide spectrum of payer mix. Next slide, please. So this is a breakdown, just a map that shows the types of practice ownership by health system owned, clinician partially owned, university owned across the state. And so this is where we're going to draw our sample from that allows us to get the kind of regional variety, the ownership structure variety, and the patient populations that they serve, the variety and diversity of that. And so we're going to take a random sample of 30 practices, 10 from each of these three different types, from practices that, according to our survey, in the past 5 years have either moved from clinician to hospital system ownership, stayed clinician owned, or stayed hospital health system owned. And I'm thinking we might also expand our sample by add another group to this, just because we've seen this more recently, of practices that have moved from hospital ownership back to clinician owned, back to private ownership. There's several that we've come across, at least in the past year or so, that are doing that as well. Next slide, please. So just very briefly, this is a sequential explanatory design. So we're going to do structured questions, Likert scale questions through a multimedia survey. Basically, what we're going to do is collaborate with some of the NASAM authors who made the high quality and the whole health reports. And we're going to distill the domains of high quality primary care and whole health into small little descriptions, small little summaries. Put a multimedia presentation together, somebody watches it, hears that, and then takes a survey immediately afterward to assess their attitudes towards those different domains, whether they agree with them or not, their current practice around those different domains, how well they're being able to act on those different domains of high quality care, and then their confidence in being able to improve that in the future. Importantly, the survey instrument will also assess experiences and perspectives related to professional satisfaction, work environment, and practice culture, because we want to be able to understand the context in which these other things are happening. Next slide, please. We're going to, within a month of a practice team, and practice teams are 3 to 5 clinicians, and this could be physicians, APPs, or nursing staff, or any other kind of ancillary teams that are on the clinical teams. Once they all completed those surveys, we're going to be able to look at them, look for trends in them, and then go and do focus group interviews with those practice team members. And the point of those interviews is to delve deeper into into those attitudes, current practice, and confidence. And so understand why are they saying that they agree or don't agree with the different domains of high quality care and whole health. What are the things that are contributing to, that are facilitating or undermining their ability to provide that type of care? And then we're also going to be able to identify and describe other organizational practice and individual factors, so other contextual factors that might be informing their responses. Next slide, please. And what we hope to get out of this work is the knowledge of understanding how and why practice ownership and other factors, contextual factors, help or hinder the delivery of high quality primary care. And where we're going to instrumentalize this and make it pragmatic is integrating it into our future projects that we do within our PBRN and that we do within Virginia, so that we can help address the barriers to transforming care models that might be contingent upon different ownership settings, so we can better plan for and tailor the intervention to different context specific variables. And then the idea is also then to expand on this study in the future beyond Virginia, so to be able to incorporate a more diverse set of practices, to be able to look at these trends, and then to include non-clinician practice members, so front staff members or other parts of the team that beyond just direct patient care, and also talk to patients themselves. And then the idea being also to track changes longitudinally, so to see how this changes over time, and to go back to practices as they experience these shifts in ownership or changes, and see how that changes over time in the future. Thank you.
Let's have Jane and Amelia, can you rejoin us on camera? Thank you. And I hope it's okay to be on first name basis, or I guess even if it's not okay, I tend to do that. So it's primary care, what can I say? So thank you all for your terrific presentations. It stimulated a lot of really provocative questions, comments. I'm going to try to organize some of them um, for you. I think one of the things that's important to say, and maybe you could just briefly comment, there's a lot of questions. The ultimate aims of your research all include trying to look at the impact of these trends. I think, right, we're at the stage where what you were able to present today is where we are with describing these trends, but then the next stage of your research, right, is to say, how is this affecting people working in primary care, patients, communities, correct? Do you want to just kind of reemphasize that that is kind of what comes next with your studies? Amy, do you want to take a stab? Just, yeah. I think you may have to unmute on your.
Let's see, can you hear me now?
Yeah, that's great.
Great. Maybe I'll just say all this quantitative work to look at causal impacts requires, I think, as Dr. Zhu had talked about, as I've talked about, this construction of this really careful databases, and it just takes time and a lot of effort. And so I think a number of groups are doing that around the country. And yes, so part of this is just constructing these databases and then asking, using kind of quasi-experimental methods, saying, what's the impact of these changes? So really important to the quality and cost of care.
Thanks. Jane, same with yours, right? I mean, you're going to be looking at Medicare beneficiary data, right? Claims.
Right. Yeah. I mean, like we said, the larger aims of the project are really to understand what is the impact. I think what I'll say is Dr. Bond mentioned there's a lot of different groups looking at this across the country, and everybody's using sort of a slightly different methodology, maybe a slightly different data set. What's reassuring is that through sort of these careful manual, sort of building of these data sets, the contours of what early research has shown has really been fairly similar. Outside of quality of care, which is much harder to measure, but the impact of consolidation writ large and of private equity specifically raising prices and spending and potentially and showing changes in utilization. These are all sort of compared to, I saw one of the comments like, are you comparing before and after private equity acquisition? Yes, that is the whole point, is to try to get as close to a causal estimation as possible. What is the isolated effect of private equity buying up these practices? The majority of, at least in private equity, the research, the comparison group has been on independent practices. And I think that's part of the reason that Dr. Bond and her group trying to come up with what is a health system and what does vertical consolidation look like, it gives us a different counterfactual because the reality of the situation is private equity is not being compared to independent practices, which are, getting fewer and farther between over time. It's really being, at least this is also the argument of people who are proponents of private equity capital, for a private practice trying to stay alive right now against these larger health systems and hospitals. It's sort of a Hobson's choice. It's not how do we remain independent? How does private equity compare to that? It's how do we, how do we stay afloat if we're being sort of approached by private equity and we're on one hand, and we're also being approached by hospital X or health system Y or Optum on the other hand. And so I think all this coming around to say, I think the work that Dr. Bond and her group and others are doing to sort of get at the bigger picture of what does, how do we look at the structures and ownerships of all of these different entities in healthcare is really important to get at what is the impact, not only compared to sort of an ideal counterfactual independent practices, but to the real counterfactual, which is all these other consolidated health systems.
Jane, can I just add a quick follow-up? Because somebody asked about like direct primary care, which I think this is really helpful to make the distinction that in some ways private equity is moving in not to buy up giant health system practices, right? It's really in that more into what used to be the independent sector or smaller groups are they starting to buy up direct primary care practices?
Yeah, it's interesting that you asked. We actually have, as part of this project, a little parallel, which is we started collecting data on direct primary care and concierge practices. And as sort of an alternative, there's this pendulum is sort of swinging from these large consolidated health systems to primary care doctors wanting to sort of have autonomy over their schedules and their care and their patients. And that's become a huge growing source. So what we've seen in that early data is about 9,000 physicians, clinicians that we've associated or affiliated with direct primary care and concierge practices, and in fact, a 400% increase in the acquisitions of those practices by corporate entities. So it's really interesting that people are going towards direct primary care as a way to get away from consolidation and to get away from corporatization. But in fact, the corporate entities are going there as well.
I think I won't editorialize on that because there's a lot of comments that are making editorials there that I'll let people read, but I think it is rather revealing of where some of these forces are going. Hey, Marshall, you highlighted in part of your whole health, right, elements equity as an important aspect of primary care that's been called out by various NASEM reports. There's been some questions in there, and I wonder if all three of you could address. Are you trying? Are your studies planning to look at potential differential impacts, whether it's of private equity acquisitions, whether it's trends in consolidation and ownership, how it might differentially affect rural practices? I mean, somebody mentioned how private equity has been associated with, let's say, closure of rural hospitals or consolidation, right, Amy? I think large systems buy up and then proceed to close smaller rural hospitals. Are you planning to look at, does this play out differently in rural communities, smaller practices, rural health centers, looking at, other marginalized population aspects and the effects of this may play out differently in Medicare, Medicare beneficiaries, for example? Could you speak to that? Maybe, Marshall, maybe starting with you. Is that something you're going to look at?
Yeah, I would say for my part, sampling practices that are both in rural and urban settings and looking at practices with different payer mixes as well. So seeing practices that have higher percentage of Medicaid populations or even uninsured populations and to see if we can see differences in that. And again, we're not going to be able to look at necessarily in terms of health disparity outcomes, but we can assess practices awareness and motivation to work on those types of to work with those patients and proactively incorporate that mode of care. But yes, for my part.
Yeah. Amy, you were about to, yeah.
Yeah, I think that's a wonderful question. We're thinking about that, but actually in a slightly different angle. That I think we saw earlier that about 50% of primary care physicians are tightly affiliated with a health system. And so we've gone about this thinking about, well, not all health systems might look the same. And so we're going to be thinking about it, well, are there different types of health system characteristics that might be associated with different impacts?
Terrific. I think one of you, maybe Amy, you spoke to this, was it's just there's a lot of work that goes into creating these databases that you can then interrogate to answer the really interesting questions. And, Amy Eden introduced by talking about this health system compendium. I think for those of the people in the audience who are interested in this kind of research, could you all speak to, or, you're doing this work, is it that there's been existing compendium databases, some of them are now publicly available, but do they need to be modified to do this kind of research? Are your additions that you're working on going to then in turn be publicly available so that other researchers could potentially take advantage of all the hard work you've done? Maybe Jane and Amy, could you speak to that a little bit, just the methodology and how much work and how we can make this more available to the research community?
Maybe I'll say a couple words purely because I think mentioned it throughout my presentation. and Dr. Zhu also talked about this, each research group is coming about this in a slightly different way. We've prioritized in part because our partner is Mathematica to make our database available so that people will be able to kind of use this and map it onto their own data. That being said, a lot of researchers to kind of like make it a little bit better are using data that's just not going to be, they're not allowed based on data use agreements to make it publicly available. I think that's actually something that's really important and wonderful about AHRQ, which is sometimes as in academia, you need to move on to the next thing, and having AHRQ kind of as this backstop to say, hey, this is important, please make this publicly available. It makes us pause to think and promote that as part of our grant.
Jane, any thoughts from your?
I just want to echo that. I think the manual work in finding acquisitions, at least from our perspective, is replicable, and it shouldn't be duplicated so many times by different groups because it takes months to years just to find these acquisitions. And I really would encourage, more sharing of those resources when possible. And we did write into our grant, as part of this, we would be happy to share our private equity acquisition list. And I have done so in our other work with states that are looking at regulatory measures or wanting to evaluate private equity activity in their own environments. But I do agree that should be more widely disseminated. And then, but on the other side of that, because we're using IQVIA data, we have a contract with IQVIA and we can't share the rest of it. So there are efforts here that have to be duplicated, unfortunately, and that slows science down. And I think, if there were ways to get around that, like AHRQ is doing with the Health Systems Compendium, that's certainly welcome and encouraging.
Yeah, just for, so we're about to close, but I think this is really such a critical issue. Not maybe it's just a research wonk in me about the databases, but IQVIA, I don't think everybody's necessarily familiar. IQVIA, IQVIA is a acronym. PICOS, PECO, these are all like commercial. I mean, these are through commercial firms that you have to purchase them from.
PICOS is
federal. Federal, okay, the federal IQVIA is a more private, but they're not so easy to access. So I think, Karen Rhodes, I saw just put in a comment, Karen, Dr. Rhodes was formerly at AHRQ. There was a subcommittee at AHRQ that really had put in a recommendation for the Health Systems Compendium to focus more on primary care practices and really create a publicly available compendium that would have a lot of this kind of work you've been doing incorporated into a national data set. Again, uncertain times for things like federal data sets and agencies and maintaining these, much less enhancing them. But it seems to me that your research is really demonstrating how critical this, how much work goes into this, how it would be a real public resource to the research community and to the public at large who would benefit from these findings, to have databases that ideally an agency like AHRQ could help support people to develop, and then have a repository that would be accessible more broadly for researchers. All right, I did have to end on my own editorial, I guess. I think, thank you. Seeing lots of thank yous in the comment, Mark. Again, just to bring this home, I mean, in this tone, this is really important work. So again, all supported by our great researchers like you, all different in how you're approaching things. This has such implications that people have said in the commentary. Does this affect people? Does care, Marshall, you said maybe, could it get better? Could it be more integrated? There's certainly concern from hospitals. Maybe care suffers. Maybe there's downsizing of the workforce that happens to extract more profits. These are such critical issues. And I think all of you started by saying we know almost nothing about how this plays out in primary care. A lot more work been done in hospitals. So you've done us all a great service by shining a light on how these really dynamic system effects are playing out in primary care. And I think everybody's looking forward to hearing about what you find from the next stages of your research. So on behalf of AHRQ, APT, I think everybody who attended, thank you so much for sharing your work with us today. And I think with that, we will close up. Thanks so much, everybody.